All right, so this lecture is going to be on emergent diseases. So we are intimately familiar right now with how emergent diseases can work, but we're going to talk about some historical ones and then kind of compare a little bit what numbers are important in different emergent diseases, infectious diseases, of course, because we don't necessarily have the same type of statistics or care about the same type of things if it's an emergent disease, so a disease that is new but seems to have a different cause. So, like a newer genetic condition or a disease of old age that we're seeing now because people live longer, things like that. So, what we're interested in are the diseases that are infective, so you can pass them from one person to another. So, an infectious disease that has not previously been described or has not been common for at least 20 years would be an emergent disease. The spread of these has increased because of globalization. You know that in the last couple of months, that's the big thing that we heard was air travel, restrictions on air travel out of China, restrictions on air travel now out of Europe into the U.S., despite the fact that we have cases here as well. But we're seeing these restrictions. The same thing happened during the Ebola outbreak that was not too long ago because it started in Africa and people were wanting to stop its spread. All right, so I'm going to talk about a couple examples. First is acquired immune deficiency syndrome, or AIDS. This is the disease caused by the human immunodeficiency virus, or HIV. HIV is a retrovirus. It causes AIDS, of course, and a retrovirus just is the way that it manages and transfers information with RNA. So it's a little bit different from other viruses because of that. Now we think, go over here, I pulled up some tabs so that we could talk a little bit about HIV and AIDS. So this is a organization that works with education on HIV AIDS. They do fundraising for research and prevention and stuff too. But what I wanted to point out is that it was believed that HIV actually originated in Kinshasa in the Democratic Republic of Congo around 1920 when it crossed species from chimpanzees to humans. Now, a lot of these diseases that cross from great apes, so chimpanzees, gorillas, or even some of the monkeys, so not apes, but monkeys, to humans, a lot of them are going to happen in Africa because that's where people come into contact with these animals. And a lot of times people will be eating these animals as bushmeat because that's what they have available for food. Up until the 1980s, we do not know how many people were infected with HIV or developed AIDS. Probably it crossed into humans around 1920, and it was probably in a fairly small population. So it may not have actually infected too many people because it may have just been more localized. HIV was unknown and transmission was not accompanied by noticeable signs or symptoms. It wasn't until patients developed AIDS that they would have known anything was wrong. And even then, when they're living in smaller parts of Congo, they may not have been able to get medical care. And so what they had may not have been known even after death. There were sporadic cases documented prior to 1970. We can go back in the medical literature and recognize some of the signs that, yeah, this was an AIDS case based on the data that was collected on the patients. The current epidemic started in probably the mid to late 70s, and by 1980, HIV may have already spread to 5 continents: North America, South America, Europe, Africa, and Australia. And during that period, we believe that between 100,000 and 300,000 people would already have been infected. So because of the way that this disease works, where you have HIV for sometimes years before you develop AIDS, so you're asymptomatic for years, but you can still pass on the condition, we think that by the time we noticed it, there were already a lot of people worldwide who were infected. By 1981, cases of a rare lung infection called pneumocystis carinii pneumonia, or PCP, were found in 5 young, previously healthy gay men in Los Angeles. This was around the same time that there were parts of a group of men in New York and California with an unusually aggressive cancer called Kaposi sarcoma. In December 1981, the first cases of PCP were reported in people who inject drugs. And by the end of the year, there were 270 reported cases of severe immune deficiency among gay men. 121 of them had already died by that time. So this is really the first onslaught of deaths, and of knowing that these things were probably linked because they were happening in people in the same area, who were probably in contact with each other. So people who may have been in contact with each other, that's a good clue that it might be infective. So this was kind of that initial thing. Now, you can go through and read about the whole history of the AIDS epidemic. There's a lot of sad stuff in there, a lot of not moving fast enough because a lot of people thought that this was what patients deserved because they were gay. And that's just, I think, heartbreaking. But you can read about it and go through all of this thing. There were a couple of moves that different places made at the time, like San Francisco closed bathhouses and private sex clubs because of high-risk sexual activity. Because at that point they knew that this is how it was being transmitted, that it could be transmitted that way, and that it could also be transmitted via the blood, so by body fluids. But there's all this information about all these different moves that different governmental agencies did to try to raise money, to do research, all this kind of thing. And unfortunately, if you go through and read all of this, which, I mean, it's enlightening. It takes a lot longer to get to the point where we're doing like a lot of research into it than you might think, because, I mean, it just happens like in the early 1980s. That's when we first started seeing this. That's like 40 years ago. That's not that long ago. We also originally thought this poor guy, I'm not sure how to pronounce his name, Gayton Dugas. He was a early HIV patient. He died in 1984. He was a Canadian flight attendant, and he was initially thought to be patient zero, or the primary case for AIDS in the US. And in some media, he was kind of portrayed as someone who didn't necessarily care about others and who like almost intentionally was spreading this disease. It probably, this New York Times article from a couple years ago, it probably arrived in the US long before patient zero. I mean, there's lots of evidence that he was not, in fact, patient zero and has just become, all right, well, you can read that if you subscribe, that he has just kind of become a scapegoat for the HIV AIDS crisis. So there's a documentary, I believe, about him that you can watch, about his role in the North American AIDS epidemic. And the reason that he was kind of singled out is because he was an AIDS patient, and he was a flight attendant. And so there was this idea that he was presumably promiscuous because of his occupation and his being gay, and that he probably was just flying to all these different cities and giving AIDS to a bunch of people, giving HIV. So that's HIV AIDS. All right. And I do encourage you, it's a very interesting story. We just are not going to spend the entire class time on that. Ebola is the next one I want to talk about. This is an infectious disease with high death rates. It's caused by the Ebola virus. And every once in a while we have an outbreak. Ebola can cross from monkeys into humans due to like transfer of blood. So if you are hunting a monkey and you kill it and get blood in your eye and it has Ebola, then you can get Ebola. And that's how we think that it crossed into humans. Once it's in humans, it's passed on again by bodily fluids. The problem with this is that people who have Ebola, it's a hemorrhagic fever, which means you get a fever and you bleed. And so a disease that is passed by bodily fluids like blood, and then you bleed when you have it, and as you are infected and then dying, is not a good combination. One way that we have slowed and stopped Ebola outbreaks in the past is by educating the people who live in communities where it's happening to not perform their same like funeral rites, because a lot of the funeral rites in those areas involve like family and friends cleaning the body and taking care of the body. And when you have a body that is from a person who died of Ebola, there's a lot of infectious material still there. So that's one way that they have really cut down on infection. And when we had the Ebola outbreak just a few years back, one of the biggest things they were worried about was air travel. They didn't want people to travel to the US with it. We had a couple people come to be treated at the CDC. And it was like they were basically locked down because people were scared. Mad cow disease is another good example. This one went from cows to humans. It's a disease in which prions or prions mutate into deadly pathogens and slowly damage a cow's nervous system. It can be transmitted into humans by eating contaminated cow meat. So beef that has been contaminated with these prions that are in the like nervous tissue. So typically, mad cow was found in like ground beef products. It wasn't as common in things like steaks because those didn't have a lot of like nervous tissue mixed in. Mad cow was a pretty big problem in the UK for a short time until they figured out what was happening. They, shut down how different like packing plants were working. They got rid of the cattle that were infected. But still to this day, if you were in the UK during a certain time, you cannot donate blood. I think it hasn't changed recently because of mad cow disease, because they don't want the chance that you have those prions. The prions themselves are proteins that occasionally mutate into a pathogen. So these are just tiny proteins, but when they mutate and they change shape, they are pathogenic and they can cause other proteins to change shape, which causes this cascading effect. These are like brain proteins, so proteins found in the nervous system, especially in the brain and spinal cord, and eventually it can cause like nervous system issues. So loss of like muscle function, loss of memory, all these kinds of what we would think of as neurological symptoms. There are a couple of examples of prion diseases in humans, and actually there is some research right now into how prions may be the cause of things like Alzheimer's. It's super interesting. I have a book if you wanted to borrow it and we get back to school before the end of the year, all about this. It's by Stanley Prusiner, who is the researcher who is one of the main guys who discovered this. I've met him and he is really interesting, and this research is really cool into how these prions are actually probably behind a couple of these neurological diseases that we know of. All right, next I want to talk about swine flu and bird flu. So swine flu is H1N1, bird flu was H5N1, and just give you some of the stats, especially because these are in the news a lot right now because of COVID-19. So bird flu, H5N1, it occurred occasionally. It is difficult to transmit from person to person, so it had a very low R0, or reproduction rate. The mortality rate, though, was about 60%. So that is a huge mortality rate. So people who got it, it was like 60% of those people would die. This was not good. But our R0, I don't know if they've actually published this number, so we'll see if it comes up. Estimation of the reproductive number for epidemic, highly pathogenic H5N1. So the R0 is basically the number of people you would infect if you had it. So they don't know the true basic reproduction number. They're looking at like a couple different other substrains, it looks like here. But it wasn't very infective. So this is the only reason why like this was not too bad. It's typically low for the flu. The R0 for the 1918 pandemic of flu was around 2, which is pretty high because then you can get exponential growth. Swine flu, which is H1N1, this death rate was very low, but it was more infective than bird flu. The death rate was just about 0.02%, so pretty low death rate. Around the same percents as like the seasonal flu. So it was around that same realm. And I say around because seasonal flu changes every year. So it's really hard to know like what is the true of the seasonal flu because like it depends on the flu year. Sometimes it's higher, sometimes it's lower. Here's CDC has lots more information on H1N1. It was just a decade after that pandemic last year. And this one was not as bad of a pandemic as we have seen. The previous thing that was a pandemic before this one was the 1918 Spanish flu. And then, of course, we have the pandemic that we are currently in right now. And the reason that the swine flu doesn't get as much of like the press or wasn't as like worrisome is a couple of things. Here's a good summary of those things. So this is just comparing the COVID-19 pandemic to that swine flu pandemic. And a couple reasons. Number one, H1N1 was not very effective. Also, it didn't end up killing as many people as we had feared that it would because it wasn't as effective. It had a lower R naught than it could have had, and because it wasn't as deadly as it could have been. Just like with the case with COVID, initially, we weren't sure what the death rate was going to be because the initial cases that we were catching were all pretty bad ones. So initially, we weren't sure how bad it was going to be. But it became apparent pretty quick due to testing in the US and Mexico, because this started in Mexico, or at least we think it started in Mexico, that it was not, that it didn't have a super high mortality rate. The mortality rate of novel coronavirus is much higher. We think it's about 2%. In some places, it's estimating around 6%. It really depends on the availability of care, because a lot of people who have coronavirus or COVID-19, they are requiring, the most sick people are requiring intubation and respiration as part of treatment. And in places where they can't get that, the death rate is higher. So it really depends, this death rate number, the mortality rate, is probably going to move around quite a lot over the next several months as we see different countries dealing with the outbreak. Some countries are not going to be as well prepared as others, and some countries are trying to make moves in order to not have to be as well prepared. So a number of countries that only have very low numbers of cases are already doing the same things that we're doing in the US and that Italy is doing, where they are preventing people from moving around. The things that China started and South Korea did very well when they had their initial cases. So some countries have maybe 9 cases in the country and are still taking those steps because they know that they don't have the medical facilities if it does get very bad there. Now, the reason that we are, concerned about that is because of these R naught values. So for 1918, the median R naught value was 1.8. There was a 1957 pandemic flu that was seasonal flu, but it was a little bit worse than normal flu at 1.65. We've got a couple other years of flu. The 2009, so that swine flu, was 1.46. So that is our R naught value. So those are some of those R naught values from past cases. And of course, this paper doesn't include our current COVID because it was published in 2014. So it can't see the future, right? The R naught value we are believing for COVID is somewhere in this article, which is why I kept it up. R naught is estimated to be between 2 and 2.5. So that means for every person who's infected, they are going to infect 2 to 2.5 people. So that means we can get growth much, much more quickly than we could with swine flu, where the R naught value was 1.46. So for every 1 person infected, they would infect 1.46 people. This, as we saw when we studied exponential growth, those small changes in how many people are infected from 1 person can be dramatic changes overall, because you get that growth much quicker. And this is why social distancing and self-isolation are really helpful, because we can lower how many people are infected, because we can't change the R naught value. The R naught value is, or should be, based on the infectivity rate. So how infective is the disease? But what we can do is we can change the actual R naught from this pandemic by changing how many people other people come in contact with. There are a couple other things that are of issue with this. One is that with the swine flu H1N1, people saw symptoms within a couple of days. There's more information in here, but H1N1, people usually saw symptoms between 1 and 4 days. And with the current COVID-19, it's taking longer for some people to show symptoms. And when people are asymptomatic, they can still pass that on. So that's one of the concerns about our current epidemic. So that is, or pandemic. So that's a little bit about swine flu, bird flu, and COVID-19. Which COVID-19 will not be on the AP exam this year because they don't do like current events stuff. But it might be in the future. So, not that you guys care, but it might be helpful to know that those other things, just in case they put a question about a pandemic on there that is more general. All right, SARS is another coronavirus, severe acute respiratory syndrome. And SARS was more easily controlled. Again, it probably had a smaller R naught, although I couldn't find the R naught number for SARS. So I'm not entirely sure on that one. But that one stayed mostly localized, probably because of the R naught and because of early things that were put into place to prevent transmission. West Nile is a virus that lives in hundreds of species of birds and is transmitted among birds by mosquitoes, and it can jump into humans. Not good for the humans. Zika virus, another carried by mosquitoes, causes mild flu-like symptoms in adults, but microcephaly in fetuses. And when there was an outbreak of Zika, we noticed this problem with fetuses. So previously it was just a mild flu, but then we suddenly noticed that this increase in cases of Zika was related to this increase in microcephaly in infants. So not good. Ecological examples include white nose syndrome in bats, which is caused by a fungus. The fungus grows on the bats while they're in hibernation, and it prevents them from being able to stay in hibernation, which usually makes them wake up frequently. They can't get any food during those wake ups, and so they end up starving before the end of winter. California sea lions have herpes 1, and this is likely from human sewage, but there is an epidemic of herpes virus in California sea lions. And that's where we're going to stop. The next one we'll pick back up with conservation medicine, but just to give you an example of a couple of these pandemics and epidemics that are in animals as well.